Good morning. My name is Dr. Hubka. I'm a thoracic surgeon at Virginia Mason, and I'm pleased to be involved with this Zoom presentation of treatment of lung cancer in the time of our COVID pandemic. At Virginia Mason, we are a very busy tertiary center that takes care of patients with all stages of lung cancer from both our immediate urban Seattle area, but also our region of the Pacific Northwest. We do so in multidisciplinary fashion, and I'm pleased to introduce my partners, Dr. Stephen Kirtland, who is head of our Pulmonary division, and Dr. Joseph Rosales, who is head of our Medical Oncology division, and they're both specialists in treatment of lung cancer. To introduce the topic, lung cancer is a serious oncologic problem. About 135,000 people die of lung cancer annually, and our goals are to benchmark our care of lung cancer with prompt multidisciplinary review, workup of the patient locally, and then our and visit to our regional medical center with therapy ordinarily within 2 weeks. We have a multidisciplinary tumor board where we review every lung cancer case, pre-therapy, guide additional workup, and then try to get a patient to therapy as soon as possible. Now, obviously, this entire system got strained by the current public health situation, and we had to adjust the ways we do work and evaluate patients. This was impacted by the patient's ability to travel, and of course, our ability to have personal protective equipment, the strain on our hospital with COVID infection. And as such, I would like to discuss this topic with my colleagues. So let me start with you, Steve. How did the COVID pandemic impact the way you take care of patients?
Well, I think that there's a number of factors that are involved here. So first off is the patient that um, is ill, can't come in, or is impacted directly with the virus itself. Obviously, those folks who are ill were asking to stay home. So um, that impacted it. From a standpoint of then adjustment of resources within the institution. So, Virginia Mason, like a number of other institutions, had to shift their priorities to be able to provide enough access for the potential of the pandemic reaching critical levels regarding hospitalizations and things like that. And so, the hospital itself said for the fact that we needed to maintain enough PPE, we were not going to have patients, elective patients, come in. And then I guess I would say thirdly, in regards to cancer care, it became somewhat of a balance. And I think each case was taken individually between the balance of public health issues regarding limited resources and the aspect of now you're dealing with a clinical care that is obviously time limited, meaning these folks have a potential for malignancy or a known malignancy, and are dealing with their own personal crisis in a sense, and those folks needed to be couldn't wait. And so I think those were the struggles that we dealt with, and I think not only did we as providers deal with, our patients and their families dealt with as to how do they balance those different challenges. And so I think the topic of today's discussion regarding the aspect of the use of telemedicine in dealing with this type of challenge or crisis, frankly, it became a a very instrumental way of dealing with these folks.
Yeah. Um, one thing that you touched on is really what we refer to as shared decision making, where we try to discuss the potential harm of proceeding with therapy and the potential harm of not proceeding with therapy in concert with discussion on the impact on our both hospital and societal resources with the patient, and together with the patient, and we then make a decision regarding the next best steps. Joe, that is uh, most true really of patients with advanced cancers. Can you elaborate on shared decision making and how that changed during this time?
Sure, absolutely. I mean, I think you bring up a good point, but within the context of COVID, it's narrowed down, but it is also part of decision making with regards to cancer treatment in general. Whenever you have somebody with a diagnosis of cancer, the question is always risk versus benefit of treatment versus no treatment. And for the majority of patients with lung cancer, it's almost always in the direction of wanting to give treatment as appropriate. The big question in many cases is, should patients receive chemotherapy? And that's a decision that we make with patients individually, regardless. So there are some patients for whom the choice is to be as aggressive as possible, and in that case, you might want to be permissive of giving chemotherapy even at lower stages. Similarly, there's patients who are older, perhaps more frail, that you would consider giving chemotherapy in other situations, but they might not want to do it because that's not their focus. In the setting of COVID, you have to take into account the extra added risk of, well, what if you give somebody chemotherapy in the setting of a pandemic? What you're doing is you're potentially decreasing their immune system, making them perhaps more susceptible to both getting it, but also perhaps more importantly, having an adverse reaction when they do get it. And so that needs to be taken into consideration. The other side of this, of course, is that there's only so long that you can delay cancer treatment. In the beginning, when the COVID pandemic was starting and we didn't know exactly what we were dealing with, we were hoping that we could push people out a month, a couple of months, still be within their window receiving chemotherapy. Now we know that we're probably going to be dealing with COVID in the ambient environment for the next year, maybe longer. And so in that case, it's not really feasible to delay chemotherapy. So now what we're doing is we're making the decision of chemotherapy or not individually from COVID. We take it on a case-per-case basis based on what the patient's stage is, their underlying physiology, and whether they would need chemotherapy in any case. Once the decision is made to get chemotherapy, then what we've done is made sure that we have protocols in place to try to minimize the risk to patients over and above what we would normally do. Like for instance, so in the chemotherapy suite, everybody that comes in is checked for symptoms beforehand. They get called 1 or 2 days prior to make sure they're not symptomatic. When they come in, their temperature is checked and they get screening at the door. They're asked or they're required to wear masks, and we're minimizing the number of patients, the number of people that the patients are able to bring in to try to minimize the impact on the system. That being said, whenever you're able to do that, I think it's always better to just treat according to the patient's clinical characteristics. And so the decision to treat stage 1A to stage 3C with chemotherapy in large part is going on as per previous. We just want to make sure that we're able to do it in a safe environment and try to minimize the risk for COVID moving forward.
Okay. Steve, one of the biggest differentiators in survivorship in the recent years has been lung cancer screening. We run based on the National Lung Cancer Screening Trial, we run quite a robust lung cancer screening program at Virginia Mason, and also at Virginia Mason Memorial in the Yakima Valley. And obviously, there has been some changes with respect to resources and also with respect to patients' willingness to be to undergo screening or to present to a radiology center to be imaged. How were our screening numbers impacted, and what do you think will be the downstream effect of that?
Yeah, that's a good question, and it's one that we struggled with right at the beginning. We had to make some policy decisions regarding screening and follow-ups, and so we again, folks who are purely screened, meaning they don't have a known nodule that's being followed, those folks, we felt it was safe to push out at least a few months. Now, as Joe mentioned, that policy is changing now because well, number one, thankfully our numbers within King County at least have decreased, but also the virus is part of the community, and we obviously can't push out screening more than a few months. But for those, we felt for those patients who had a known abnormality that needed follow-up, that those folks really shouldn't miss their timed scan or screen, and those folks were contacted. The other aspect of this that did play a part somewhat is our own staffing. So our own staff was, as most other groups, there were staff that were furloughed, and most of our staff that run the screening program actually did it remotely from home, which was done really quite effectively. But to answer your question, so those people who are getting their annual screens with no abnormality were delayed a few months. Now, how that will impact, I don't know that we know. We now have reinstituted our screening programs, starting back up after delaying about two to 3 months.
Gotcha. So I'm a patient who has a locally advanced lung cancer, which spread to lymph nodes, and I was able to undergo a resection and made it through okay. And now I'm to receive chemotherapy. What are my normal risks from, as far as my immune system goes, of receiving chemotherapy?
Sure. For nowadays,
chemotherapy, that is.
Sure. So in terms of baseline risks and sort of treatment paradigms, the recommendations nowadays for patients with node-positive lung cancer, status post-resection, are to receive adjuvant doublet chemotherapy, a combination with cisplatin and some other medication, usually cisplatin Taxol, cisplatin pemetrexed, a couple other different regimens. The standard is to receive 4 cycles, and there's different ways of giving it, but a typical way is to give 1 dose every 3 weeks. And the reason why it's like that is because it takes 3 weeks really to recover from the full range of toxicities from the chemotherapy. And so that would be a standard recommendation for patients who would be in that hypothetical scenario. The standard risks of that are kind of the usual risks of chemotherapy. They're brought about because chemotherapy really doesn't know the difference between what's a cancer cell and what's a normal cell. The way the chemotherapy, cytotoxic classical chemotherapy, differentiates is it can tell the difference between a fast-growing cell and a slow-growing cell. So cancer grows fast enough, quickly enough, that it can be killed by chemotherapy. Other cells in the body that grow fast enough can also be killed by chemotherapy. Your hair, for instance, grows very quickly. The lining of your GI tract, your bone marrow, those are therefore the cells that are affected the most by the chemo. So when we talk about general toxicities of chemo, we focus on those. Perhaps the most common day-to-day toxicity are GI, nausea, vomiting, diarrhea, sometimes constipation. They're the most common. We also have a lot of medications nowadays that can mitigate those. And for the majority of patients that get chemotherapy in this setting, they're otherwise fairly healthy, and therefore we can try to minimize the impact of their day-to-day. They'll probably feel the nausea, but it's not like how it was, even 5 or 10 years ago. Certainly not how they show it on TV and movies where you're vomiting the whole time you're getting chemotherapy. We can do a lot of things to alleviate that now. The second sort of most problematic toxicity of chemotherapy in general, and perhaps the one that has the most bearing in the setting of the COVID-19 pandemic, is immune suppression. So the blood cells are made by the bone marrow. Your bone marrow is making cells pretty much on a daily basis. And so because of that, blood cells can be severely impacted by the chemo. When you have red blood cells get lower, you get anemic, you get tired. When your platelets are decreased, you're at risk for bleeding and bruising. Perhaps most importantly, if your white cells are affected, then your immune system is diminished also. And even in the absence of a pandemic, we worry about that because having low white blood cells put patients at risk for infections like bacterial infections, pneumonia, viral infections. And if you have a high concentration of an ambient viral infection in the community, you worry that by doing that, you're increasing the risk for patients. And so we do take that into consideration. In the beginning, there's an ongoing debate right now of whether or not giving patients chemotherapy in the setting of a COVID-19 pandemic puts them at significantly higher risk. It's a difficult question, and ideally, of course, we wouldn't want to give chemotherapy in this setting at all. However, the downside is that if somebody has realistically, stage 3 lung cancer, the use of chemotherapy impacts their survival so much that you wouldn't want to not use it if appropriate. And so in that case, we would still move forward with chemotherapy. Again, talking about like the safety features that we kind of incorporated into the system now compared to before, but we would not necessarily withhold chemotherapy in this.
Well, let me ask you a question. So pretend I'm a primary care provider who is a
safe a manner as possible.
Sorry for there was a little disconnection, but
oh yeah.
So pretend I'm a primary care provider and I have a patient who needs cytotoxic adjuvant chemotherapy for stage 2 lung cancer. What are my chances of getting admitted to the hospital? So what do I tell my patient? You should wait for to get chemo, or what is the chances of an inpatient admission because of the side effects?
Yeah. Oh, and just first of all, I certainly wouldn't wait. Whether it's COVID or not, the traditional window for giving chemotherapy after surgery is within 2 to 3 months. And the reason for that is because when the studies were done, that looked at survival benefits, the patients who were enrolled in the study were able to start chemotherapy within 12 weeks of surgery and recovery. So I certainly wouldn't wait. And given how long we're going to need to deal with this pandemic, there's no benefit to waiting at this point. You need to be able to give chemotherapy as safely as possible. With regards to risks, with regards to risks of admission, generally speaking, the kinds of chemotherapy that we give for lung cancer, in the grand scheme of things, they're not the worst chemotherapy in the world. I mean, they're still cytotoxic. I don't mean to minimize their impact, but they're not as toxic as other chemotherapy regimens out there. And while they do have the ability to give significant toxicities, it's unlikely nowadays that patients who are receiving adjuvant chemotherapy for lung cancer end up in the hospital. The rates of admissions for chemotherapy complications, specifically for lung cancer chemotherapy, are exceedingly low. I'd say less than 2 to 3% in the proper setting. And so the likelihood of somebody getting that sick from adjuvant chemotherapies where they end up in the hospital and therefore have to expose themselves to the risks of the system are very low.
What do you tell your patients who are currently undergoing chemotherapy? How do they behave? Do they behave differently at home? Do they not go to the store? Do they stay locked up in their homes? What do you tell them?
Yeah, great question. Basically, we agree with the social distancing, and in fact, we tell the patients, if at all possible, take it to an even more of an extreme case. Try to minimize their interactions, at least certainly during the 12 weeks or so that it would take for them to complete the entire course of adjuvant chemotherapy. Try to minimize going to the store. Interact only with the people within their homes. Even family interactions. If the family don't live with them, we try to minimize that also. Afterwards, after the 12 weeks, once they're recovered, perhaps you can consider loosening them up, at least based on what the recommendations are for the rest of our state. The downside is that patients with even just a history of cancer, not even people who are undergoing active therapy, but people with a history of cancer do have a higher risk of complications if they end up getting coronavirus. And so because of that, I would consider patients with a history of cancer, even not active cancer, on the same lines of patients who have diabetes or other immune suppressed states. And therefore, we certainly would try to minimize their exposure to coronavirus as much as possible.
Well, I'll tell you on a slightly different topic. We've struggled in the world of thoracic surgery on how to make the best decisions for and with our patients. We've had patients present with all stages of cancer, I had a patient from Alaska who had a very large right-sided lung tumor and needed a right-sided pneumonectomy. And this was just as the cases were ramping up, and we did not know whether we can anticipate 60, 70 intubated patients in our hospital, and how does it impact not only the individual patient, but as we discussed, the hospital resources. And so I initially sent the patient back to Alaska and then ended up operating on him about 3 weeks later when it appeared that things have stabilized. Similarly, with early stage cancers, we especially in our octogenarians and our elderly patients, we struggled to make the right decision and to delay their surgery as long as possible. Although once the situation reached this plateau we are in currently, we thus far very successfully resected all those patients. Part of the part of what I perceived that was very helpful was our multidisciplinary tumor board. As you both know, we meet once a week on Wednesdays, but our entire flow of work has changed. I mean, similarly to this presentation via Zoom, we all sit in our offices, as do our radiologists, pathologists, radiation oncologists, and we present our patients. We present anywhere between 8 and 18 patients a week. And Steve, how do you find this new process, and how do you think it's going to go from how do you think it's going to impact our future of multidisciplinary review?
Well, that's a complex question, and I would tell you that I think one of the first points I would say is, through this pandemic and challenge, that I think we've remained true to the fact that we have maintained the appropriate and high quality cancer care that we were providing even before the pandemic. I think that needs to be stressed.
I agree with that.
I think one of the reasons why we've been what I would call successful in doing this is the fact that as an institution and as within Thoracic, the Thoracic Center, we are a fairly flexible and nimble group and innovative in regards to how can we provide that high quality care while maintaining social distancing, while respecting the patient's concern regarding coming to the hospital. And so a lot of things we had in place beforehand really became paramount, as by that I mean navigation for the patient became absolutely essential. As we coordinated care, if we found that a patient needed to come down for a procedure, a lot of the pre-work, as you know, would be done beforehand. Discussion at the multidisciplinary conference, scans close to home if for our patients that were away, and they would come down, and we would oftentimes meet them via televideo and review their scans with them through televideo, which actually turned out to be quite satisfying for both the providers and the patients. And I would say we were able to accomplish what we were doing in person for those type of visits, 90% of the time. And so patients limited their exposure to the hospital significantly. And then by the time they came down here, they understood, they were ready. And as Joe said, there were just like in medical oncology, in the procedural area and the surgical suites, there were we put into safeguards, if you will, as to the number of people that can come, how they check in. Of course, like all institutions, we are masking and temperature checking all our employees. And as I've told patients now, I think Coming to the hospital now is much safer than going to the store. It's like getting on an airplane after an airplane crash is what I tell them. We are so hyper vigilant that I think the precautions that we're taking will guarantee that patients will be safe when they come here. And I think that's held true, and people are satisfied with that.
Yeah, I can tell you that, you know, with changing in staff availability, we in thoracic surgery were able to maintain a steady volume of, for instance, robotic thoracic surgery, from which patients clearly benefit in our institution, but that requires skill task alignment among employees who are trained to do this work. So our kind of timing and scheduling has changed a little bit, but I'm very proud of the team. We were able to um, offer that to our patients even in this difficult time, and maintain our clinical outcomes, which were a little impacted by staffing, as you pointed out earlier. And as in pulmonary, in thoracic surgery, we take various precautions and we'll talk about pulmonary function tests, but of a flow of patients through the hospital and of testing. How, Joe, if I may ask, in the medical oncology, I'm sure there are patients who are nervous to come and get chemotherapy. What specific precautions or extra steps are you taking in the medical oncology and department and the infusion center specifically to mitigate this?
Okay, it's a good question, because that was a question that we've been debating really for the last couple of months, and how extensively to implement some of the recommendations from the national bodies and guidelines. At the basic level, like what Steve was saying, everybody that comes into the building, the entire building, not just medical oncology, at the door, they're tested. They're asked in terms of their symptomatology. They're given masks. Their temperature is checked to make sure that there's nothing that even resembles the possibility of a symptom of coronavirus. In addition, they can either only come by themselves, or at most can bring one other person that can be with them throughout the course of their treatment. That would minimize the exposure potential. There have been some patients who have opted to actually wait elsewhere, and we just call them when they're ready for their appointment. A lot of times they'll wait in their car, and if they have a cell phone, we can just call them. What we've done is minimize the interaction within the waiting room, basically, so that people aren't quite as together. We certainly are maintaining social distancing in there. Throughout our history, patients have had their own rooms anyway, so we don't really have too many shared rooms for patients. And at this point, we're not using any rooms as shared. Basically, everybody gets their own room for their infusion, and they can have their family members in there with them. Our staff are always masked and with a face shield as they give the chemotherapy. And so all of those things to try to minimize the wait times, and to try to minimize the interactions when we're doing those kinds of things. The big question, and this is something that we still struggle with now, and I don't think anybody has an answer, is how often to test patients, especially asymptomatic patients for coronavirus. Of course, patients who have symptoms, they get tested, and then we would only treat if they're negative. However, as becoming more and more known in societal, in the news, it seems like there's a significant portion of patients who are either minimally symptomatic a long time ago, or were asymptomatic completely, who ended up testing positive for coronavirus. And we honestly don't know how to deal with those patients, because we don't know, are they about to get symptoms? Have they recovered? Are they still able to shed coronavirus and expose other people? And so there's an ongoing debate in medical oncology in general, is before you start patients on a potentially immunosuppressive therapy, should you test them for coronavirus if they're asymptomatic? And I think that as a community, we honestly don't know the answer to that question. There's a lot of sometimes heated discussion in terms of when to do that. Ultimately, after a lot of back and forth, what we've decided is that we are not going to be testing asymptomatic patients. As a general rule, we are not going to be testing asymptomatic patients before starting treatment. And part of it is because we don't quite know exactly what to do with that data. For instance, if, let's say, somebody's asymptomatic but they test positive, are they safe to give chemotherapy to? Probably not. But if that's the case, how long do you wait for? Is 10 to 14 days enough? Should they clear the virus? Should they be completely negative? Is it safe to wait that long for somebody who obviously needs chemotherapy? And is the risk of waiting greater than the risk of exposing them to potentially coronavirus infection? So we don't quite know what to do. Plus, and a lot of people have brought this up, well, there's no reason why you would only test in the beginning. If you're testing people before each procedure, shouldn't you test them at each cycle? And we honestly don't know if that's the proper way to go. There are some situations where we acknowledge that patients probably upfront should be tested. For instance, those who have hematological malignancies like leukemias and lymphomas, just because they do tend to be more immune suppressed than typical. And plus, those are the kinds of regimens that tend to perhaps require a stronger chemotherapy and then have more long-term toxicity. So there are some situations where we would test patients for coronavirus if they're asymptomatic prior to giving chemo. But as a general rule, we haven't done that. And I don't think there's any consensus in the country or in the world in terms of doing that. So outside of that, we're pretty much doing everything like what Steve was saying. We're kind of perhaps maybe being overkill in terms of how often we're cleaning our stations and making sure everything is wiped down. But I think until we know more about how easily or how difficult it is to transmit and acquire coronavirus, I think we're probably better off sort of just being more cautious than we normally have been in the past.
Yeah, we in surgery and all the procedural areas, obviously we test every single patient prior now within 48 hours of their operation. This is especially pertinent with lung cancer surgery because not only patients need a special breathing tube, which takes a little longer to place, and the exposure to our anesthesia colleagues is not trivial. But for instance, when we do robotic surgery, we positive pressure insufflate the affected hemithorax, and that results in some aerosolization of and possible virus shedding, and we don't really have enough understanding to make the best decision. Now, the downside to this obviously is that this inconveniences our patients tremendously because they often come from out of town and they have to come beforehand. Testing is not available at their local center, or the test results are not easily obtainable for us to review pre-procedurally, which then can delay or change scheduling, which we're trying so hard to maintain due to our staffing issues. And that is really the downside of COVID. But I would like to talk about a possible upside, which is really the main silver lining of the COVID-19 pandemic, appears to be the broader adaptation of telehealth. And as much as we inconvenience our patients with all this extra testing, we have really committed, I think, as individuals and as an organization, to implementation of telehealth, not only primary care, but in specialty cares like surgical care, pulmonary, oncology, and really cancer care. And I've done a number of telehealth, both phone and video visits with our patients. And I would really like to ask you guys, how do you perceive telehealth in your own practice? Steve, let's start with you. And then how do you perceive the future of telehealth in care of our lung cancer patients?
Well, when this pandemic was peaking, of course, I would tell you the majority of our visits were televideo visits. Now that things have calmed down, I would still tell you that about 40% of my visits are televideo, in part because the patients really appreciate them. Yesterday, a patient from Alaska, outside of Juneau, said, I didn't know this existed, and this is a great way to continue follow-up. I don't have to fly down there. You can show me the films. And so I foresee a lot of visits for those patients, obviously, who live a distance, for both pre-procedural, pre-surgical, and those patients who follow up. And as we know, in post lung cancer surgery or chemo or radiation therapy, these folks are followed for years, often with scans, and now that can be provided that way. I think there's two other aspects though that that I've been thinking about. One is, think about it now. when we see our patients face to face, we actually are wearing a mask and they see little of us. And it's actually more impersonal to see them face to face than it is televideo, where I can sit in my office and they can see my entire facial expression. So that's one kind of ironic aspect of the change of care. The other potential benefit is what you see here, is the ability now to have multidisciplinary visits. And we've been doing this in the neuromuscular clinic for a number of years, face to face, and now we've converted those to telemedicine, and it's really worked quite well. Again, these are patients that are physically impaired, and it's quite an ordeal for them to come downtown, so they appreciate from that aspect. But the other aspect that's unique is I will often it's a very coordinated dance, if you will, as we all have times that we come on, but we'll often one or two or even three providers may be on at the same time as one is finishing, one is introducing the next provider, saying, hey, you know, Mrs. Jones, for instance, in my neuromuscular clinic, the speech pathologist will introduce me and say, you know, she's been having problems swallowing, and that becomes a big that's an aspect that obviously from a pulmonary standpoint is very important. So I see potential from a standpoint of patient satisfaction and being able to not only really accomplish most of what you accomplish in a face-to-face visit. Obviously, you don't have the physical exam, um, and that is an impairment. But you know, a lot of the things we do during a physical exam, you can almost do via sight. And now with significant individual monitoring, people show me their oximetry, their pulse, their blood pressure. So I get almost the same amount of vitals I get when they come in. But we can provide now multidisciplinary discussion in front of the patient, and most of my patients have found that quite satisfying. Before I end, I will Joe knows this patient. Talk about a silver lining to COVID. Joe and I were introduced to a patient who came down with a COVID infection. And as part of her evaluation to determine she had COVID, she had a CT scan, which showed the classic bilateral peripheral ground glass opacities consistent with COVID, but also showed a large left lung mass in a woman who lived alone and was relatively young. And then it became, as Joe said, it's when is the right time in somebody who has an active COVID infection, but has a you know, most likely 90% positive or plus chance of having a lung malignancy. And here came the balance of priorities. And we chose in this opportunity, we followed her closely via televideo and with monitoring of her symptoms, and when she became well, we started doing or asymptomatic, I should say, we started doing COVID testing. Initially she was positive, and once she turned negative, we brought her in, did a procedure, diagnosed her with malignancy, and now she's going to be thankfully had an early stage malignancy, and she'll go on to have curative resection. Had she not had COVID, she wouldn't have found the lung mass. So a bit of a silver lining, if you will.
No, I agree with you. There are two other points I would like to make. One is that I think the technology is here. Just look at us this morning. We are interacting very naturally. You know, there are no hiccups, and I think the technology is here, as is as are various forms of remote monitoring. You know, now there are apps to record EKGs and various surrogates for physical exam, which can be transmitted electronically. The other added advantage is that when I interact with patients via video, I can see the background and I can see their home and I can see their family members. Oftentimes family members can log on onto these visits from elsewhere in the country. I can see whether they have barriers in their homes and how those barriers will impact their post-operative recovery. The one, the one uh, uh, hindrance of this type of interaction, they say, and I didn't find it to be a problem, but is establishing rapport, especially establishing rapport with a new patient. I would ask Joe, and obviously we are talking about lung cancer patients who are facing the most challenging decision and the most challenging immediate future they've ever faced, and they're going to interact with a provider, and they need to establish rapport with that provider and a connection, whether it comes to surgery or systemic therapy. Joe, how do you deal with that, and what recommendations do you have for us with respect to establishing rapport over telehealth visits?
So I think a really good question, because I think that many people, I mean, I'm sure you guys would agree that a lot of times the relationship with the patient is established with that first visit. And many things that get discussed and that happen during that first visit are what maintains the relationship throughout the course of treatment and beyond. And much of that is nonverbal, how you talk to the patient, how you examine them, how you touch them in that way. And so you do lose that, I think, by doing the televideo. And I think that, because of that, it's sort of, it's imperative that you're able to develop some sort of rapport in a different manner. What I've found, and this has not just been for new patients, but for patients who are undergoing treatment, one of the potential benefits of televideo, and I think you touched upon this earlier, Steve, is the number of touch points that you could potentially have. For instance, it's not uncommon for me to see a patient in initial consultation when we all see patients, on that same day or 2-day period when they see pulmonary, radiation oncology, surgery, have their scans. And then when that happens, everybody sees the patient, they go through the treatment plan, they get presented at the cancer conference, they have their surgery or whatever procedure, and then I see them back, but not until 3 or 4 weeks later. And at that point, they're already in the system, but I haven't seen them in 3 or 4 weeks, and it's time to reestablish rapport. What I've found with potentially what we can do with telemedicine video is you can actually have more touch points. Like, for instance, it's not uncommon, like Steve was saying, you see a patient once, and then let's do this again in a week. You don't have to come in. You live an hour and a half away. You don't have to come in just to talk to me, but we can do this on video, and you can have an ongoing conversation. A lot of times, many of the things that I tell them on that first day are, they're there, but they don't register because they get so much information. However, a week later, they've had a time to read up on things, they can process things, they're able to have more specific questions that are specific to their situation, and we can have a deeper conversation. So I think having multiple touch points throughout the initial portion of treatment makes a big difference. In fact, I'm doing that now. This is somewhat transformative for my patients who are undergoing treatment. So when patients come in for chemotherapy, a lot of times I'll see them when they come in, once every 3 weeks. During that first cycle, that's when most of the symptoms will happen, but you don't really know exactly which ones will happen because you don't know what happens until you give your first dose. And a lot of times, the patients will have nausea or fatigue or more than they would expect, but they don't know to call, and you don't necessarily talk to them on a regular basis. What I've incorporated now is have patients maybe 7 to 10 days later, when they're expected to be at the worst of their toxicities, 7 to 10 days after that first cycle, we'll set up a televideo, and they can just talk and they can see, well, what happened? Do you need more nausea medication? Should I give you medication for mucositis? Those kinds of things. And while we tried to do that prior, it's really hard, because if they live an hour and a half away and they're already feeling kind of bad, they're not going to want to come in just to we'll do a side effect check. Whereas nowadays, you're able to do that because you do have the ability to have multiple touch points, even if they're not as in depth as they used to be. The sheer number of them are able to kind of overcome that. And I think that that's one big way in which our practices sort of change to be able to have that kind of relationship with the patients, even over video. And I think that if we're able to do this beyond the time of COVID, that would be something that would be pretty transformative for my practice in particular.
Well, that brings me to my last question, Steve. Where are we going with telehealth? where are we going to be 5 years from now? What do you think?
It's a great question. I'm sure everybody has their own opinion regarding that. I think, as like most crises, it creates chaos, which creates transformative change. And I think we will see. I think our patients have experience, and we have created new ways of visiting with patients, as Joe mentioned. Now a change in practice pattern that actually is nothing but for the betterment of the patient. They have an interaction with a provider from their home, and it may be as brief as 10 minutes now, but think about having to drive in, park your car, come in and see the provider for 10 minutes, and then go back home, as opposed to now they can do it from their home. So I think I can't imagine that we're going to go back to the way things were. There obviously there are certain things that have to be done at a medical center. Those will continue. But I think as innovation continues, as home monitoring improves, I would imagine a lot of our outpatient visits will become televideo visits. I'm already promoting those type of visits for my patients who live out of town or have any reticence for coming in. So yeah, I think that the future is going to look a lot different than 3 months ago.
I agree with you that the proof of concept during these last 2 months has worked, and telemedicine and the impact that the technology has had on our lives recently is here to stay. I do, however, hope that, I do get to give a patient a hug once in a while after surgery still, because I do get a lot of personal satisfaction out of that. Gentlemen, I thank you very much for this experimental Zoom CME. I think it's a testament of how well this technology works, and I love you both very much.
All right. Well, thanks for
Right
inviting.
back at you, man.
Bye-bye.
Bye-bye.
Bye-bye.